Hi, I'm Dr. Eric Westman, and this is the Keto Made Simple podcast. Hi, everyone. Dr. Eric Westman here, and in my channel, I review and debunk nutritional misinformation online, typically. But every now and then, I get to interview, it's my great pleasure to interview the movers and shakers in the low-carb, keto, even nutritional, and even now psychiatric world. And it's my great pleasure to have Dr. Bret Scher with me today.
Thanks, Eric. It's so great to be here. I can't believe this is the first time sitting down to have this sort of conversation. We've been sort of working in tandem for so long in this field, so it's great to be able to be here with you.
And my great pleasure. I was trying to think back to when we first met. It's been a while, but I have to say you're one of the first cardiologists that I met who kind of, I got into this world of obesity treatment, and Dr. Atkins was a cardiologist, but I wasn't treating heart disease, and then all this other stuff changes where triglyceride and HDL get prominent in the blood, but not all cardiologists think that. And so it was reassuring to meet you and to see that maybe I wasn't as crazy as everyone said I was. I mean, this is 15 years ago. So I wonder, could you start, to someone who doesn't know who you are, where you trained and how you got into the idea? You have, there's still a website, Low Carb Cardiologist, and you wrote a book, Your Best Health Ever, just for those who don't know that. And so who are you? How did we come to cross paths?
Yeah, well, thanks. Thanks for the opportunities. Well, so I started off as a general cardiologist, but my focus was always prevention. So when I did my fellowship here in San Diego at Scripps Scripps Clinic, it was a combined general and preventive cardiology fellowship. Now, interestingly, the preventive clinic there is an Ornish style program. So that's where my fellowship training was.
Which, for those who haven't heard that term, and refreshingly, there are some who don't, that's the ultra low fat version of
Correct.
diet.
Now, it is a lifestyle program, right? So it's stress management, it's exercise, it's, quitting smoking, it's community support, and it is also a very low fat, predominantly vegan diet. And so that was my preventive cardiology training. And then so I went out into the, quote unquote real world and my regular cardiology job. I really did want to focus on prevention. And, there I'm doing a mix of the cath lab and the hospital and the ICU and the outpatient, getting a mix of all of it and saying, something's not right here. The way we're trying to help people, we're great at putting stents in, we're great at helping people who are having heart attacks. It seems like we're pretty bad at preventing them and really helping people get healthy. And why is that? And, trying to bounce around to figure out why that was. And at the time, I just thought I needed to spend more time with the patients because they needed someone who understood physical activity, who understood nutrition, who understood behavioral management and behavioral decisions. So I went and I got training in all these areas. And then I opened up a wellness center with a friend of mine. And fortunately for me, though, he was well-versed in ketosis and ketogenic diets, just by chance. And so on a couple of our patients who, their blood sugar was out of control, they were overweight, and no matter what we were saying, it wasn't really resonating with them. And he said, hey, how about we try a ketogenic diet? And my first response is, what, are you crazy? I can't do that. I'm a cardiologist trained in.
Now, what year was this, just for context?
Was this 2000? It was probably 2012, I want to say. Yeah, somewhere around.
Well, so the science on low carb diets for obesity had been out, for 10 years, but I don't know how many people read that, but you're
right. So to his credit, when I responded, he said, well, have you read anything about it? Have you looked into it? And I said, well, no, maybe I should. So I remember finding a study or two by this guy named Dr. Westman. And I said, hey, there's someone's actually done research and published on this. And I never learned this in cardiology. I never learned this in my fellowship or even my internal medicine training. And all of a sudden I'm like, okay, well, that's interesting. I never learned it. Why don't we try it? Tried it on myself, tried it on a couple patients, started reading more about the literature. And then I got like really upset. I'm like, oh my God, this works better than anything I've seen for weight loss, for managing metabolic health, which is connected to cardiac health. Why have I not heard anything about this? And then that sort of set me off on this mission that like we need to make sure people know about this. And not that everybody needs to be on a ketogenic diet, but this has to be a treatment option that every doctor knows about because of how well it can work and how much it can help people. And that sort of started me on my journey. And from there, became the medical director at Diet Doctor, where we did focus on ketosis for medical conditions for improving your metabolic health. And then about 2 years ago, transitioned over to Metabolic Mind, where I'm now the medical director of Bazooki Group and Metabolic Mind and run the podcast there, focusing on ketogenic therapy for treating mental illness and other brain-based disorders. So it's just one more area where everybody, every clinician needs to know that this is a very, very powerful medical intervention and not just, eating bacon, which U.S. News and World Report says we shouldn't do. It's completely different.
Although eating bacon is fine.
Yeah, eating bacon is fine, but if people say, ketosis is just that diet where you eat a bunch of bacon, and like a doctor is going to think that, and that is very common, as opposed to ketosis is a medical intervention that dramatically improves your metabolic health, that changes your brain chemistry, that can treat seizures, that can treat cognitive decline, that can treat mental illness, that can put type 2 diabetes into remission, which is a term I never heard of when I was training or in the early stages of my career. We didn't talk about remission of type 2 diabetes, but here there's a dietary intervention that can do it. So, yeah, you can tell I'm getting a little worked up just talking about it already. Just the fact that
It's good.
we need everybody to learn this.
There was a book some years ago. I think there's another like revisiting the tipping point that Malcolm Gladwell was the author, and he's back on writing a new book or has one out. But the crux of the argument in this book, to have something tip, you need different types of people. Like you need so Steve Phinney to me is like the guru, nutritional genius, but he can't spread the word, right? So enter in Dr. Bret Scher, who develops this knack and great skill. It's a skill of interviewing with podcasts. I mean, it's something we're not taught that in medical school, right? And so, but you're positioned in a place that is unique, and that you've been able to interview so many different people in so many different areas. I wonder what. Do you have a clinic now? Like when you sit down with a patient, or if you're talking to my patients, what have you learned? Where do you start with patient care now?
Yeah, so for patient care, I still have an online preventive cardiology practice, telemedicine. I'm licensed in 7 different states, so I can still see patients, and I still focus on the connection between metabolic health and cardiac health, and how they are really, really intimately related, and you really have to address metabolic health first to address cardiovascular health. A big percentage of my patients are people who are following keto diets or low carb and have high cholesterol or have heart disease, and they want someone who's going to do something different than just guideline-based care, and see them as an individual. So that's where my clinical practice is, and then I'm not, and then I'm the medical director of Bazooki Group and Metabolic Mind as well. So sort of 2 different hats. But
Yeah.
but yeah, I mean, look, you're absolutely right. We have luminaries like Steve Phinney, like Dr. Phinney and Dr. Volek and you, and people who have really sort of paved the way, but we need we need thousands of people out there with megaphones, letting everybody know what's going on. And you mentioned the podcast, and I've had different iterations of my podcast, and I remember thinking when I started, I don't care if anybody's listening. These are just such fun conversations to have, to learn from everybody. But now I really do care if people are listening, because it's just so important for individuals and for clinicians to learn this, especially if it's not being taught. And look, we know the way mainstream media reacts to headlines and clickbait and sort of misrepresents the the results of studies, or at least the reach of studies, and we need people talking about the the underlying nature of what it really means and what we really should be taking away from it, which is a hard message to get out there.
Yeah. Well, so let's sit just a moment in your primary specialty of cardiology. So I trained at University of Wisconsin, University of Kentucky, at Duke, and Duke kind of cardiology rules. They're the ones who got the initial money for drug trials, and they have the big building downtown. If there's a big building in Durham, it's basically the Duke Clinical Research Institute, and they've been funded by pharma and driven in the cardiology world. And it was only recently in Chicago I gave a talk at the Illinois Obesity Association. They have a pretty mature state level obesity meeting. And one of the young doctors came up to me and just kind of shook his head about cardiologists today. He said, my field, I'm internal medicine. He's a former chief. And he said, cardiologists, all they want to do is lower the LDL down to zero, and they don't know anything about food. And so he actually does a low carb friendly or keto friendly practice. So what is it about cardiologists and cardiology, and can we accomplish perhaps just a different way of going about things as a diplomatic
Yeah,
strategy?
can we accomplish a different way of going about things? I think we have to. We absolutely have to accomplish a different way of going about things, and that's seeing heart health as a broader picture, not a lab value of LDL. That's not heart health. And also metabolic health is not the presence or absence of type 2 diabetes either. But we've seen these data, these tables, whether it's from the Women's Health Initiative or from the recent study in New England Journal of Medicine, that sort of put into perspective the contributory risk to heart disease of type 2 diabetes, of metabolic syndrome, of lipoprotein insulin resistance scores versus LDL or ApoB. And they're all on the list. They all contribute, but type 2 diabetes, is a hazard ratio of 10, and metabolic syndrome of 6, and ApoB of 1.8. Okay, so it helps put it into perspective. And in the New England Journal article found something, almost identical to that. So it's seeing cardiovascular health in a broader picture, which we really have to do. But the problem is we don't have great drugs for insulin resistance. There's like metformin, and that's about it. Now people would say the GLP-1s, right? Of course, now we have the drug that's good for everything. There was an article that came out like, oh, GLP-1s are good for arthritis. They reduce knee pain. Okay, well, I don't think they're like helping you build more cartilage in your meniscus. They're, you just lose weight and things happen. So you improve your metabolic health, things happen. But there are better ways to do it than expensive injection medications. But that's what we're not good at teaching and talking about and working with as a field. As a field of medicine, not just cardiology, but kind of medicine in general. And you've probably seen it from the Obesity Medicine Society, and you've been so involved in that, and they're just all about GLP-1s and GIPs and the next generation, and not about stuff.
It's like, so I'm past president of the Obesity Medicine Association, and it's like King Midas came through, and everything's gold now because it's pharma. The meeting that is bigger, better. They're free meals at the evening dinner sessions. You know how that works.
Yeah.
We're in infancy compared to the cardiology meetings that have so much pharma influence. But so it seems like the one fulcrum point or tension is fascinating, and that's that darn pesky LDL. And I kept pushing the slide from the Verta data. Everything gets better except the LDL. Everything better. Then I woke up one morning thinking maybe it's better for LDL to go up. At least in this context. And then I'm talking to a pilot and a patient had some time to talk, and I said, well, if you look out the window and your altimeter says 5,000 feet, but you're on the ground, well, you're in Denver. I mean, you're geographical, you're on a mountain. So if you only look at a number and you don't look out the window, it's a sea level where the altimeter would say 0, but so we're looking at one number totally out of context. Is it an underappreciation of the metabolic change that diet can make, or is it an over appreciation and over treatment with drugs for one little thing, perhaps?
Yeah, it's both. I mean, it's both. It's because we become so focused on LDL then, and in the pharma sponsored research, there's so much research around statins lowering LDL and reducing very slight reduction in the risk of heart attacks, because that's where all the money is and that's where all the studies are. And look, I this is where I get in trouble in low carb circles sometimes. Like, I prescribe statins all the time for my patients who've had heart attacks and had stents and had bypass surgery, or have evidence of soft plaque on their CT angiogram. Like, I use statins in those situations, but by no means is that the one be all treatment. That is a small part of the broader treatment plan, which has to involve lifestyle and nutrition and improving metabolic health, because that is as important, if not more important. So, why have we become so focused on it? I mean, there are lots of reasons, but I think that's why, because that's where the majority of the research is. It's the majority of the research funding is, because people aren't funding the nutrition studies that we need to show the benefit that they're going to have.
Well, to that point, I mean, we have to be honest and self-critical that I'm not aware of any study where lifestyle has addressed metabolic syndrome in a randomized type of study prospectively to show that it's better than the typical treatment. Are you aware of any kind of study?
It's a great question.
I am, or even the treatment of metabolic syndrome with a drug compared to no treatment. I'm not aware of any. I mean, it's not even on the radar of the scientists that I'm aware of. But so, to say that metabolic syndrome is so important and that diabetes tenfold risk. I mean, we're still talking about cohort studies where I train all my patients are trained to say, correlation, not causation, or nutritional epidemiology. But
right, and we have to use. There are studies with surrogate markers, like you mentioned, the Verta studies that they've published. In their 1-year trial, they showed that there was about a 10% increase in LDL with no change in ApoB, but a 12% reduction in calculated cardiovascular risk. Okay, that's not a proven reduction in heart attacks or longer lives. It's a calculated cardiovascular risk, but it should wake us up to say, oh, okay, look at that. LDL goes up, but there's more to it than just LDL, because this calculator that we all are taught to use and is supposed to be so important actually shows a decreased cardiac risk. So, where do we put that in the scheme of things of a 5-year pharma study that actually shows, 0.5% of fewer heart attacks versus a surrogate marker that's a calculation of a reduced risk, right? We have to balance that, but that's what we as clinicians have to do.
Well, and then on the other side of things, though, that for those who are naysayers about low carb or keto research and say we're killing people, prove it. Man, so I'll go to a meeting and say, no, show me a study where someone on a well-formulated keto diet, had more risk and more death. And it's like we're dealing with prejudice, not only in the populace, the popular press, but also among doctors, where it occurred to me. So Jeff Volek and I collaborated on one paper, and it was in the late 90s, and we looked back to see if there were any data to say low carb diets were good or bad, and actually there were a few that said it was good. And now 20 years later, I asked Jeff Volek at a recent meeting, is there any evidence that low carb keto diets are bad? And he said, no, there's no evidence. And I thought, oh my goodness, why have I been defensive for 25 years when there's really no evidence that it's bad? Oh, right. The epi studies where they take 30% carb or less is a low carb diet, and they take pot shots. They take an anecdote of, anyway. So really, there's no study that says it's bad either.
It just shows complete misunderstanding, though, that you can see the lay press, but also the medical community will look at a study that uses 37% of carbohydrates, which could be 200 grams of carbs per day, and say, okay, that was the low carb group. Low carb did worse, therefore low carb is bad. Keto must be bad. Like that is actually what many clinicians believe, because that's what the journals say. That's what they've been, that's what they've been taught. And if they sat down to actually think about it, they probably would understand. But, busy clinicians don't always have the time to do that. But that's got nothing to do with a ketogenic diet or a ketogenic intervention. And I mean, you mentioned Jeff Volek, and he just did this fantastic study in Ohio State using ketogenic interventions to treat depression in college age kids. And it's to be published soon. But I mean, if you can treat your depression and you can change your life and you can change the way you see things, are you going to worry about, a 10% increase in your LDL, especially if you're improving your metabolic health? And same for, what we do at Metabolic Mind. We just see story after story after story and studies showing people putting their bipolar disorder into remission, their schizophrenia into remission. Again, things we never heard about, like type 2 diabetes, into remission. We didn't talk about these things, but it's possible. But they're hung up on the LDL, just like you said, that they're so focused on the LDL. It's the classic not seeing the forest through the trees analogy.
Well, I'm thinking the kind of, I can be writing editorials now, which means the bar to get it published is a lot lower. I mean, there's still a minor review process, but I think my next one will be the different lab values have different meanings under different circumstances. Like the altimeter, if your altimeter says 0 and you're in Denver, I mean, you're subterranean, right? So the idea that the LDL doesn't mean the same thing, perhaps, even just, I guess the old story is Galileo wasn't killed because he said it was his hypothesis that the Earth wasn't at the center of the universe. So I'll say my hypothesis is maybe LDL is different under different circumstances, but then there's the ketone level is different. Perhaps the ferritin level is the A1C and glucose may be a little elevated. It's fascinating to see the knee-jerk reaction to this is necessarily bad.
Yeah.
Because it's not carb eater level blood work. How do you put that all together? And then I'm sure you're following Dave Feldman's cholesterol code study from the Citizen Science Foundation.
Yeah, absolutely. Yeah. So there's a lot there, but like talking about having to interpret tests differently, like a fasting blood sugar is the perfect example. Worthless test in my mind, worthless test. But yet that is a test that we're using to diagnose prediabetes and type 2 diabetes. And how many completely metabolically healthy people eating low carb and doing intermittent fasting have a fasting blood sugar of 108, which is prediabetes. But that's their highest sugar for the whole day. And the rest of the day, they're in like the 80s and 90s. There's no way they have prediabetes. But because of the way we've defined that one test, their doctor's going to tell them they have prediabetes. And that just shows the fallacy of the way we interpret so many tests. And you're absolutely right. I mean, that just proves your point that we need to interpret these tests differently. So what about LDL? Well, I mean, it is fascinating what Dave Feldman has done as an engineer, as an outsider, to team up with researchers and scientists and clinicians to say, let's study this, right? I'm not going to say I know what's true, but gosh, I really want to find out. So why don't we design a way to do it? And it's amazing to me that he's gotten sort of pushback and flack for the way he's handled this, because he's just said, why don't we investigate it? Which is brilliant, exactly what we should be doing. So yeah, their match study that came out that showed really no difference in the amount of plaque between people with LDL's average of 270 for almost 5 years versus 120 for, basically their whole lives, but for different reasons, the keto versus the non-keto, zero difference in plaque. It's not a definitive end-all be-all study, but if that doesn't get you, at least get your antenna up a little bit saying, maybe there's something here we should look into, then like, I don't understand people who aren't curious about that at all, but just dismiss it out of hand. Like, you've got to be curious about it. It's fascinating.
Yeah. Well, there are other vested interests, right? But, even the Feldman study so far, the LMHR Budhoff study, very technically, it makes sense back when I was trained, and perhaps your training too. If the HDL was that was a good thing.
Hmm.
And in this data set, the HDL average is 90 for these people, which is really high. I mean, on a even on a carb eater's normal range, it says, well, it's getting erased from some of them. High HDL is a protective thing for heart disease, and I've been interested to see that kind of erode away over time. When
Yeah.
when we were in training, HDL was kind of like the, well, let's respect that. Is it because there's no drug for HDL, and perhaps, or I even see some people saying if it's super high HDL, it's going to be a harmful thing.
Yeah.
You know
Well,
more
yeah,
detail about that?
I think there are two reasons for that. One is because the drugs that raised HDL did not improve health or reduce cardiac risk, right? So that's a big, whether it's the tirzepatide um, or even like niacin, right? They raise HDL, but they don't improve cardiac health. Then the second is there are genetic anomalies, where for reasons in your genetics and the way your HDL is made, you might have HDL of 120, 130, but it's not well functioning HDL. So it's the equivalent of like HDL of like 20 or 30 or whatever from a functional standpoint. I'm just making up those numbers, but to use the example. But
So it's not
things,
garden variety, not wild type HDL.
exactly, not wild type HDL, but it goes to the exact same point you made before about interpreting the 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 test differently for each individual. Because the question is, why is your HDL what it is? Is it because we tried to manipulate your system with drugs? Is it because you have a genetic mutation, or is it because you improved your metabolic health so much that your HDL has gone up? Totally different scenarios. Sorry, and excuse me one second, I got a cough. Talking so much, I talked myself into a cough here. Um, but totally different scenarios, so need to be interpreted differently rather than a blanket statement of saying, oh no, HDL doesn't matter anymore. Well, in those settings where you're using a drug to falsely elevate HDL or you have the genetic mutation, it means something differently than if you've done it with your lifestyle and improving your metabolic health.
Well, and I guess I would have to admit that it's not all been worked out, and I do sometimes passively allow or don't take away. I don't think I'm not in a position to have to prescribe statins. Just about everyone else uses them. They still think they should be in the water in this area because cardiology rules, but there are a growing number of even editorials because of the coronary artery calcium score and the CT angiogram, where now you can actually know whether you have the disease or not. The editorial language is interesting because it's like there's a chink in this wall of fortress of we have control, and if your blood level's up, we're going to give you pharma, because there's some loopholes now where if people don't have angiographic, even CT angiograms, if they don't have evidence of that, there's really no evidence that giving a drug will be beneficial. It might even kind of violate the idea that it might cause harm without any possible benefit because you don't have the disease. I mean,
Yeah.
this occurred to me when a cousin, I've just had a family reunion and he got a executive physical and they put him in for a false positive treadmill. He had normal coronaries, and at the end of the hospitalization, they said, here's your low fat diet to prevent the disease that you don't have. I mean, come on. A cancer doctor wouldn't give chemotherapy and radiation just because you're going to get cancer one day and everyone gets it, right? You need tissue, right? What if a cardiologist had to have a tissue biopsy of atherosclerosis? I mean, would they do, what artery would be taken, Anyway, I know
Yeah.
it's kind of crazy thought.
No, but those are all great points. I mean, there was even that study out of Walter Reed a number of years ago that showed, if your calcium score was 0, those who were treated with a statin or weren't treated with a statin, their 10-year risk of heart disease was exactly the same, statin or no statin, when they had a calcium score of 0. Now, if this calcium score was above 100, those treated with a statin did have a lower risk of heart events. So again, it's not that statins do nothing. They could be a part of the piece, but my goodness, are they widely overprescribed, especially with no evidence of vascular disease.
Have you seen the Asim Malhotra's new movie, First Do No Farm,
I've not seen,
PHARM yet?
no.
In there, Fiona Godley is the former editor of the BMJ, is interviewed, and she is so spot on so many things. Like, they've tried to get the drug companies to open up their data sets for transparency to just show there's some concern that the side effects had been kind of covered over or not accurately ascertained. But then she also made the point of, it could have been so easy to add in a dietary arm to all of these studies. So the express purpose of these trials were to show the drug was better than no drug, placebo. It didn't have to do with what was best for human health at
Correct.
all. And
Correct.
and that's kind of chilling coming from the BMJ editor. And then she also says, look, the journal, we publish a paper for a drug company. They commonly buy $1 million worth of reprints to give their army to hand out and teach doctors. And so it's in the financial benefit of even journals, who we think of as being sort of this unperturbable bastion of science. So anyway, there have been other editors who claimed or kind of whistleblow that the system was being bought, and this particular area of statin drugs has hit a chord, and it seems like it's a post-COVID, anti-vax, anti-lockdown, anti-statin. It all kind of got jumbled up together, didn't it?
Well, yeah, and I think at its core is sort of an anti like single message, right? Like, believe us, we know what's right. Like, I think that's what it is at its core, and for good reason. People are starting to doubt that now. Like anything, it can go too far, I think. But I think at its core, we all have reason to start doubting and questioning. And that's another thing. We mentioned Dave Feldman. He's been such a proponent of saying all data should be open access data. I mean, that just makes so much common sense that, we need third parties to verify this data, of course. And if not, what are you hiding? Like, why can't we? And, we've all seen this. Well, I don't know. There are statistics out there that show, if it's a pharma sponsored study, it favors the drug. Again, I forget the exact numbers, but 98% of the time. And when it's not a pharma funded study, it doesn't favor the drug, like, 70% of the time or something, right? There's such a disparity. And like, wait, science is science, right? Isn't science supposed to be the truth? But yet it depends who funds it and who designs it, which just shows you could design the study to show whatever you want. I mean, Kevin Hall is a classic example of that, with a 2-week dietary study, comparing a ketogenic intervention over 2 weeks. Well, sure, that is designed to fail for a ketogenic intervention because of the adaptation that takes place. If you want to design a study to make keto look bad, you design a 2-week study. Perfect, right? Like, okay, you can design it however you want. So yeah, of course, when pharma has a hand in trial design, that's a disaster.
Yeah, I lost confidence in Dr. Kevin Hall's work when he rewrote one of the NUSI studies, looking at the basic metabolism and energy balance, and the abstract didn't really reflect the internal methods and results. But anyway, that's another sidebar. But so, what are you up to now? But the excitement and talking about funding, maybe we don't need governmental funding to actually seek the truth.
Yeah, that's a great point. So one of the things that's been so refreshing for the work I'm doing now as the medical director of Bazooki Group and Metabolic Mind is seeing the power of a very generous and philanthropic family, how they are changing the way psychiatry research is done and the way psychiatry is practiced. I mean, we've helped fund gosh, I think maybe 10 trials at this point. I'm losing count because there are so many trials that otherwise would probably not have been funded and would not have been done. But now we have trials funded looking at ketogenic interventions for treating mental illness. And it's not pharma studied. There's no big company that has a vested interest in this. But because philanthropists are funding it, these studies are getting done. And it's an example that I hope just reverberates throughout every field of medicine, that someone sits up and says, wait a second, I have the resources and I have the passion to find out about this. And now I see I can make a difference. So let's do it. And I think that's what Dave and Jan Bazuki have really done to set an example to show that this can be done and can be done well.
And then can explain how they got involved in this to someone who doesn't know yet.
Yeah. So Dave Bazuki is the founder and CEO of Roblox. He and his wife Jan have Bazuki Group and now Metabolic Mind, where Jan is the president. But it started because their son Matt has bipolar disorder, and I mean, you can hear a story. I encourage everybody to go to our Metabolic Mind YouTube page and hear Jan tell this story. It's just such a powerful story. But in and out of treatment facilities, homeless, living behind a dumpster. And, this is a family with means and a loving, caring family. And it's the kind of story that often, unfortunately, ends tragically. Now, fortunately for them, it didn't. They were able to get him safe, get him treated, but he was never well. He was safe and he was treated, but he was never well. And Jan just tirelessly was looking through every potential treatment, and was lucky enough to come across Chris Palmer and Denise Potter and others to say, okay, let's try a ketogenic diet and see what happens. And that's the thing that changed his life. And now he is well, with no stigmata of bipolar disorder, of any mental illness. As Matt likes to say, he says he's more sane than any of his friends now. He can joke about it now. He's on almost no medications. He's playing like competitive chess again. He's got a full-time job. Things that Dave and Jan thought they were never going to see from their son again. They never thought they were going to have that son back again, and he is back 100%. So you never want it to happen to anybody, but I got to say, thank goodness it happened to their family, because now they are so passionate and so motivated that they're devoting, the majority of their philanthropic efforts to researching this, to making this known, to educating both clinicians and individuals about this, that this is a potential treatment that people need to know about.
Yeah, so the personal experience with the disease is often the motivating factor, like for doctors to start, they lose weight using a low carb or keto, or if you have a family member, a loved one whose life is transformed, you learn about it. And the idea of philanthropy, I guess, I'm not sure, were they ever, have you got to know them? Were they ever philanthropic before? I mean, is this just yet
Yeah.
another thing, or?
Yeah. So they also are, very involved in regenerative agriculture and also democracy. There's like final five voting rather than just the way we're voting now, which is, you can say a lot about our political system, but most of it not good. So yeah, they're definitely philanthropic in other areas as well. And this just hit so close to home, and they saw the impact they could have on this field. So there is not 100% of their philanthropy, but it's probably the majority of their philanthropy. But then they still do regenerative agriculture and democracy in other fields as well.
And I for those that don't know what Roblox is, you can go on and have a simulated version of Roblox on YouTube to see what it is.
Oh, yeah.
Basically a massively popular video interactive game for teenagers, right? I mean,
Well, it's for anybody really. There are
Right.
adults all the way down to kids using it. And even though Dave and Jan are they're the ones running the nonprofit. I don't work with Roblox. I don't have anything to do with Roblox, so I can't really speak to Roblox. But what we're doing with Bazuki Group and Metabolic Mind is really changing medical practice and changing how people see the use of ketogenic therapy.
Well, let me plant the seed then that there needs to be crossover, and you should get points for avoiding the banana in Roblox, or some. There has to be nutritional training somehow. You can wait till people get to the medical clinic, and we work hard, and we go home thinking what a great job we've done, but we need to go upstream and stop the nonsense about what food is or isn't, and have people understand this early on in schools. And I wonder, uh, well, getting back to the Bazooka Group, what's the strategy? What's the plan that is unfolding as a result of the work that you're doing?
Yeah, I mean, we've got a lot of fronts that we're trying to make an impact. So one is definitely research, and Dr. Shirani Sethi already published her study. Dr. Ian Campbell is about to publish his study anytime, and then we've got randomized controlled trials going on at McLean, and in University of Pittsburgh, one in Australia. Jeff Volek had wrapped up his study at Ohio State, and there are probably a dozen other trials going on right now. We're looking at different things. Dr. Guido Frank here at UCSD, I'm in San Diego, looking at anorexia, ketogenic therapy for anorexia. So the research is exploding, and it's very exciting to see. And then the second part is giving people a platform for their voice. So Hannah Warren, who's been with us probably for about a year now, she has bipolar disorder, has treated her bipolar disorder, which is now in remission with a ketogenic diet. And her experience and her passion and her ability to communicate with others, she's really using that to help give voice to everybody else who's gone through this, to help them talk about it. So for the world to know, because it's one thing to hear from a doctor. It's another thing to hear from somebody where it resonates with you and you're like, that sounds like me. Wait, actually, that sounds like me. Maybe this will work for me, right? And that's a great place to start. And then the third part is just teaching doctors, getting doctors, dietitians, nurse practitioners, health coaches, anybody who's going to help take care of an individual, to get them to learn about it. And actually, we now have some free CME up on my CME, where they can start to learn about this, and we want to expand upon that. I've already spoken at a couple grand rounds, and we hope to do more and more of that. Just we have to reach the clinicians to let them know this is an option. And again, not that maybe it's the option for everybody, but to let them know that this is an option. I mean, something that can treat not only the underlying symptoms of the psychiatric disorder, but also the metabolic consequences that come from having a psychiatric disorder or psychoactive medications. Because people who have severe depression, bipolar disorder, schizophrenia, they're dying young, not just from accidents or from by suicide, unfortunately, but also from metabolic dysfunction, metabolic diseases, heart disease. So it's all interrelated, and we have to treat those metabolic consequences. And lo and behold, there's a nutritional strategy that can treat the metabolic consequences and the underlying psychiatric disorder. That's a pretty powerful treatment that more people need to know about.
Yeah, I'll never forget the patient who came back to me. I was treating for weight loss, and she said, "My voices are gone."
Right.
Chris Palmer and I have talked about this through the years, and we had charts at the time, remember those paper charts? And I was like, wait a sec, what? And she had schizoaffective disorder with active hallucinations, up until 8 days after the treatment. And I talked to other people, oh, well, it was just coincidental, it just burned out and all, and yet we published a case study, and other case studies have been around. And I think one of the tricks or the challenges will be to get people to sustain simple versions of keto metabolism. And I've worked real hard with my company to try to get access for people to do simple versions of it, not to be overly concerned about no seed oils, and if you can't eat no McDonald's or Burger King, or I've had to learn how to help people navigate all of those areas and maintain ketosis, which is possible. So
Right.
I hope the emphasis also will be not just on yes, here's what can happen, but here's how we can keep people long-term on it.
Yeah, such an important point. The level of support that's needed and the sustainability for long-term use. When it comes to brain-based disorders, it's sort of its own accountability partner for a lot of people. Like, a number of people know that their symptoms are going to come back if they slip, and they don't want that to happen. So that's their accountability partner, which you have to admit, for 5, 10, 15 pounds of weight loss is very different than mania and psychosis and severe depression, right? The consequences are much, much different. So that in itself, I think, helps people stay on it. But that doesn't mean it's going to be easy for everybody to do long term, like any diet. A keto diet is no different than any other diet from that standpoint. Especially with our ultra processed food society that is just so it's so ubiquitous and so become almost an accepted part of society that it makes it challenging for anybody to stick with a dietary intervention.
Well, so I flip that around. Just the reason people can't follow a diet is because they're hooked on the sugar and ultra processed food,
Yeah.
which is not a diet. It's a perturbation of what nutrition, companies trying to get you to eat things you can't stop eating. So that a diet, I mean, there's more in common with a vegan, vegetarian, carnivore diet for health. There's more in common than differences compared to all of the junk food. That was uh, Lucia Aronica did the sub-study from the Stanford study looking at the
Yeah.
extremes, and they both led to improvement in insulin resistance. So, it's almost not what's happened in the internet. There's this false choice of you have to be meat only or vegetable only when really it's, what's going on inside the body. It seems to me keeping the glucose and insulin as low as is practicable with the cohort studies of diabetes and cardiovascular risk, pre-diabetes and cardiovascular risk.
Yeah.
To me, it's not so important how you achieve that. How do you kind of put together what someone should eat,
Yeah. Well, I think, the timing of this, I'm not sure when this is coming out, but the U.S. Dietary Guideline Committee just made the recommendation that we should all eat less meat. And I mean, it just drives me nuts when I see something like that. And so I did a video that basically says, look, why are we even talking about that? We should be talking about everybody needs to be healthy, right? We need to worry more about health than about individual foods. So if someone is using meat as part of their diet and they've improved their metabolic health, their A1Cs come down, their insulin's come down, their visceral fat has come down, they have more energy, they feel better. Why in the world would we want to tell that person to eat less meat, right? Like that's where the focus needs to be, not about on these individual foods, especially, we can get into the science is so bad to support the quote unquote dangers of meat anyway, but our focus is just off. And it's unfortunate, I think, because of just preconceived biases and external inputs from companies and lobbyists and et cetera, which has really just got us derailed from health. And instead, it's just industry sponsored policy and lobbying as opposed to a focus on health. So I don't care what you eat. For my patients, I don't care if they're vegan or if they're carnivore, or if they're anywhere in between. We're tracking their health markers and we're going to find what makes them feel good, what they enjoy, and what's improving their health. And we're going to do different experiments to find the right mix. And whatever that mix is, I'm okay with it as long as we're making that progress.
And may I just remind the viewer that you are a board certified cardiologist, US trained, and you're not crazy.
Thank you for that reminder.
Well, for the viewers, that's, I'm, falling away from the traditional internal medicine. In our area, doctors don't ask people what they eat. They don't even ask.
Yeah.
Can you imagine, veterinarians the first thing they'll say is, what are you feeding them? What are you feeding your dog or your cat? But,
Yep.
well, maybe, I think there's hope, of course. I'm an optimist. I would have been deep in despair and wouldn't get out of it long ago. So, and you too, clearly, right? You see some progress through the years.
Oh yeah. Oh yeah. Definitely progress. Like it's never fast enough for where I think it should go, of course. But yeah, progress. Absolutely. I mean, like we talked about when you started 20 something years ago, and when I started my clinic in 2012, and there wasn't nearly as much information as there is now, and there wasn't nearly as much acceptance as there is now. And then we have all these conferences popping up, and the community, the rally in DC, and like so much more than we ever had before. So we're definitely moving in the right direction. And I think as long as we can keep the focus on health, the focus has got to be on making people healthier. And clearly what we're doing isn't working. So, you can't keep banging your head against the wall and trying the same thing when it's not working. And look, here's an alternative that for a lot of anecdotal reports, clinical experience, and all this emerging data is showing that it works well. It's got to be an option. And we're seeing that tide start to change.
Well, and again, just as a kind of retrospective, knowing who you are and how evidence-based you are, the mere fact that you've been interviewing and being in this space for these years is very reassuring to me that you didn't bail out like, oh my gosh, what are we doing? So the fact that it just keeps getting better, the more we study it, it seems even better science supposedly will eventually find the truth. If it's fully funded to study everything, I'm afraid is the asterisk on that. But thank you so much for what you've done before and what you're doing now. I look forward to more great things from you, Bret.
Well, thank you very much. I appreciate it. And thank you for all of your work and for being a trailblazer in this area. And thanks for having me on today.
My pleasure. Take care now. If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.